Hi, this is Dr. Tom Rogers coming to you with a weekly podcast of what I call the Common Sense MD. Today I'm very excited because I have a special guest that's going to talk to us about and educate us on thermography, another way of looking at breast tissue, among other things, but we'll focus more on breast tissue in addition to the other modalities that we have used through the years. But it's been around a long time. And I want to introduce Dr. William, I call him Bill, but Amalu. And he's an expert in thermography in every sense of the word. I was introduced to him by one of my PA's sisters who has been working with him for years. She lives in New Hampshire. And so the good news is I'm probably going to be able to offer this in East Tennessee, which is going to be another great part of our practice that can really pick things up and another adjunctive way of imaging breast. So, Doctor, introduce yourself, please. And I've read a lot of your thing, and I'm very impressed. You've been on Good Morning America. I mean, you're kind of a well-known guy, way more than I am. So tell me a little bit about how you got into this and etc.
Well, thanks for having me today. I got into this technology in 1990 when we first opened our practice. And I was looking for something that we could add besides X-ray, looking at the human body, especially looking at their physiology. And so I enrolled in a postgraduate course, and the initial introduction was about the history of this technology that started in 1959. And as the instructor was going through this, I was stunned. I just said, wait a minute, hold on. Did you just say that this was first used for breast cancer screening? My sister at the time was battling breast cancer. And mammography, again, just the limitations of technology, couldn't see it. And so it went undetected. And I was like, why haven't I heard about this? So of course we didn't have the internet at the time. I went down to Lane Medical Library at Stanford and I combed the stacks. And when I was done, I just put my head in my hands. I couldn't believe it. So eventually, unfortunately, my sister passed away from this. But I know that if she had had access to this technology, it would have said, no, would have likely have caught it long before. Because as her oncologist said, typically, your breast cancer is like this. It takes about 8 to 10 years to get to the size of a dime. You've had this in your body for quite some time. And that's where thermography can get in and say, well, is there a warning? Yes, that's one of the main powers of the technology, is that it's the earliest warning, your earliest signal, maybe the very first signal that warns you and your doctor that a cancerous process might be present.
Tell me a little bit about, for our audience, exactly how it works. The cameras that image not only the breast but other tissues as well. Tell me how this technology works. It's more of an infrared type camera that detects heat, as I understand it.
Correct. That's exactly what it is. However, the instrumentation that's used does have to meet certain standards and guidelines. So it has to be medical quality and for use on the human body. And there's a lot of standards and calibration and things of that nature we're not going to get into, but the camera is very sophisticated. And that's mated, of course, to processing software, not only for capture, but for post-image processing. And that's pretty sophisticated. So we're actually taking heat from the surface of the body. The camera is a sensor. Nothing comes out of it. There's no radiation. There's nothing toxic whatsoever. There's no intravenous access. And basically, the heat coming off your body is sensed by the sensors. It's translated into an electrical signal, and it displays on the screen, and that's what we have to actually analyze. And we look for areas of heat, but in the breast, of course, we're really looking specifically at blood vessels. The neoangiogenesis process, the new blood vessels, the incorporation of blood vessels that the tumor needs to bring in nutrients and to flush out waste. So we compare one breast to another against a standard, but of course, if a woman only has one breast, we know how to read those just fine. And we grade the images just like you would see for mammograms, ultrasounds, MRIs of the breast. We don't use the BIRAD system. We use the TH system, the thermobiological system, and we grade the images 1 through 5. What's interesting is we actually had this grading system way back in the early 80s. And if you read the American College of Radiology's BIRAD, it's actually as if they copied us. It's kind of interesting. So we do have some similarities on how we grade the breast based on suspicion.
So I understand that it is very technical. The equipment's very expensive, and the environment has to be just right as well. Like I think the room has to be a little bit cooler than average, and
Yes.
you can't have a lot of light interference with it. But I like the fact that number one, it doesn't have any radiation to it,
No.
and a lot of times that when I order mammograms, that it comes back breasts are dense, and from my understanding and reading, thermography is not affected by dense breasts. Is that correct?
Absolutely. Augmentations, reductions, surgery, residual scarring has no effect whatsoever on the images.
And you're looking for symmetry for one thing. If you see an abnormality from a heat source in one, that's a little bit worrisome because, as we both know, cancer, which is defined as abnormal cell proliferation, the angiogenesis you were talking about means that the cancer is bringing blood cells in there to feed growth. Is that right? And you're picking up because it creates heat. Is that correct?
Correct. That's exactly what we're looking for.
So you're looking at symmetry, you're looking at heat signals, and the good deal about this is the early warning signs. So the way I'm taking this, again, correct me if I'm wrong, but we like to use this as an adjunctive therapy in addition to others. Like, we're never going to say you should not get a mammogram. We're always going to say this is another tool that we can use. Just like in medicine, we use many tools to try to diagnose and screen. In my practice, I'm all into screening so that we can either find something early, or if there's a signal that something's going wrong, to try to correct that before it gets out of hand.
Exactly.
Is that your feeling about this?
Well, correct. Absolutely. To start with what you were discussing, adjunctive, addition to, no breast screening technology is 100% sensitive. It's not going to see everything. That includes mammography. So mammography is adjunctive because I don't know any physician who's going to tell their patient, don't come in for your palpation of the breast. I'm not going to palpate your breast. Just go do this. No, they're always doing that. And why? If mammography is perfect and is that sensitive, why are we still doing that? Because we all know as physicians that a certain amount of breast cancers are going to be caught on digital palpation and not seen for one reason or another on a mammogram. And it's just the limitations of technology. Now, thermography is more sensitive than mammography, but it's not 100%. And if it's not 100%, it shouldn't be used alone. We need to combine things. Whatever a patient's physician wants to add to thermography, that's up to them and their physician.
I've always been a big believer in early detection, screening test, and to me, if you have another tool in your toolbox, you want to use everything you can, especially when you're talking about a deadly disease like breast cancer. I mean, it seems to me that I'm seeing more breast cancers now than ever. Is that your experience?
Yes, absolutely. The mortality in breast cancer seems to be going down because there are better treatment methods, but the incidence of breast cancer is increasing. Exactly. And like
Especially
you said,
among younger folks too, among younger women.
and that's one of the strengths of thermography. You can do this at younger ages. There's nothing toxic about it, and women who are younger can use this technology to screen. And one of the important parts about this, you talked about risk, using something as a screening. Risk assessment is really important. Are you at risk? Well, we can use the conventional risk index. You know how we do that as physicians, and we'll look at a patient's history. We'll look at if their mother had the disease, et cetera. But this one gives a patient their own risk assessment based on their individual biology. So if we have an abnormal thermogram and it sustains abnormal, that woman has a 10 times higher risk of future breast cancer than a first order history of the disease. That gives women time. Now they can work with their physicians. They know that there's this risk for them. They can work on improving their breast health. It's an incredibly powerful tool. And there's one more thing that's very important. You brought up breast density. How does this happen? Again, it's usually an imbalance of hormones over time. And we know that from the literature that unbalanced hormones, which leaves a woman in an estrogen dominant state, is the leading cause of breast cancer. No, lifetime exposure to that estrogen. This technology, because it's not looking at anatomy, it's looking at physiology, biology, it's very unique. We can actually see signs of estrogen dominance in the breast, or what we can also call a relative progesterone deficiency. Now, this is breast cancer. We're offering the ability to possibly ward off the disease.
That's an incredible statistic that you mentioned about being so sensitive, way more sensitive than a first degree relative having breast cancer. And I agree
Yeah,
with that. A lot of times when, I do a lot of work with hormones, and it's very true that estrogen dominance is a major factor. And it also depends on what type of estrogen or how you
sure.
metabolize your estrogen. That's why we do Dutch test. That's why we check your estrone, estriol levels,
Mm-hmm.
and which pathway it may be going down, the 2, 4, the 16. It seems like estrogen metabolism is very important in your chances of developing breast cancer
Mm-hmm.
and how severe it's going to be. Now, progesterone is the great um, savior, if you want to call it that. But
Mm-hmm.
in my opinion, as you know, the progesterone drops out pretty early. And so
Mm-hmm.
a lot of women, I always look at
Sure.
early hormone levels in women because even, when you hit menopause, that means your estrogen's really fallen off. But you've been estrogen dominant for years because the first thing that drops off besides testosterone, the next closest thing is progesterone. So when that falls off, you're losing a lot of protection. And I've always argued this point with a lot of the gynecologists. I was taught when I was first starting out 40 years ago that if a woman um, didn't have a uterus, if she'd had a hysterectomy, then there's no need for her to have progesterone. That's what they still teach, which is absolutely insane because progesterone has about 300 different functions. In
Mm-hmm.
fact, it may be the most important female hormone. I tell people that all the time. As a matter of fact, I take a little bit of progesterone myself to prevent some of the aromatization of testosterone to estradiol personally. So, and I also call progesterone like a woman's natural Valium. It helps them sleep. It
Mm-hmm.
protects their breasts. It not
Absolutely.
only protects their uterus against too much estrogen, it protects everything. So I always use progesterone first, and I look at
Right.
it early. And if there's any question, I do a deeper dive with like a Dutch test, and I look at the pathways. But there's a lot of misunderstanding about hormones themselves. Um, and when I say progesterone, I'm talking about natural
Of
progesterone,
course.
not
Of course. No,
medroxyprogesterone.
no,
That
no,
was
no.
a culprit in the WHI
Right.
study
Right.
15 years ago.
Right.
It was wrongly characterized as hormones cause breast cancer. I talk about this every day to my patients because
Right.
women are scared of it. They get scared of it by
Sure.
doctors and media that don't know about hormones, the truth about hormones. And they're going back to the days when they were using Premarin and Prempro. And it's just a really
Mm-hmm.
fascinating subject. It really denied a whole generation of women uh, life saving or health-saving benefits of bioidentical
Right.
hormones, which are totally different than synthetic hormones. So, you always have to look at that ratio of estrogen
Right.
progesterone. They balance each other out. And the first one you want is progesterone. And trust me, not medroxyprogesterone. We
No. No.
never use synthetic hormones of that nature. But in any event, um, so dense breast. So say we get a thermogram, and there's, I think you grade them from like 1 to 5. Is that the
Correct.
typical?
Correct.
And you get a 4, or you get something a little suspicious. Tell me what your recommendations are. Again, it's going to be up to the own personal physician,
Hmm.
and you're giving information on what you're seeing on the thermogram. And thank God
Correct.
you are reading these.
Hmm.
When we do this, you're going to be reading our thermograms, and I'm confident in your opinion. But again, it's going to be up to the doctor and patient as to what their next step will be, whether it be an ultrasound, a mammogram, an
Hmm.
MRI, which I find myself ordering more MRIs of breasts these days because, again, there's no radiation. The only problem I've had with that is that insurances are hesitant to pay. In my line of work, I don't care about insurance. I can find cash alternatives, usually with even MRIs. It's not
Sure.
that expensive. So tell me if you see something that looks kind of, like a 4 or definitely a 5, your recommendations as to the next steps to take.
Well, yeah, the recommendations are going to be pretty straightforward. It's going to be, let's get you back to your doctor and let's get some additional imaging. Let's go ahead and look now inside the breast. What might be doing this? That would be the first step.
Okay. Um, I've always kind of liked the diagnostic ultrasound, um, especially with dense breasts. But isn't an ultrasound kind of looking at a small area? It's hard to really. If you just took an ultrasound by itself, it's a really big area to look at. When ultrasound is best when you already have an area that you're kind of worried about. Is that right?
Well, there are different types of ultrasound machines. There's whole breast ultrasound. So they're using a different type of sound head. Then there's also the traditional sound head where they'll do the whole breast, moving all around, looking at every aspect. And there's up and coming technologies like QT ultrasound, which if you look at this in the literature, some of their research is very impressive. It's almost MRI quality. And so that's a whole different way to use ultrasound. And hopefully that's more up and coming. I believe they have a couple of offices that are out there, maybe 3, 4, 5, but hopefully we'll see more of that too. But yes, the idea is to let's get some other imaging on top of this.
Yes. So we're again using this as one tool. We will never say all you need is a thermography. We have other tools that we use as
Mhm.
well. Um, so say we have a woman that she scores a 3, which is
Mhm.
pretty common from my understanding.
Can
So
be.
they've got some inflammation there, but yet we send them for the workup and nothing, MRI, ultrasound, mammogram, whatever, it shows nothing. So we're going to follow that patient
Correct.
and hopefully make some other recommendations as to
Mhm.
what the cause may be. In functional medicine, we're always looking for root causes.
Right, exactly.
And a lot of times, what I find is inflammation is the root cause of most diseases. So we're looking at why is that person inflamed? What's their diet like? What's their gut microbiome look like? What are their stress levels?
Mhm.
So recommend a we recommend that we look at all that stuff and just follow it. So say we have like a 3 or maybe a 4 and nothing's found. How often should we repeat that thermography? How often
Well,
should we do that?
well, if this is a baseline patient, so we're talking about a baseline patient, they've come in for their first thermogram, they haven't had any follow up, they haven't had any recent imaging like mammogram, ultrasound, MRI. So now they've gone out, had some other imaging. What we recommend in a TH3, and again, these are all research guidelines, they come back in 6 months. So we do one interval instead of going a whole year. Let's take a look again. What are you doing? What's the breast doing? And if you're making any recommendations for treatment, then we're going to see if there's any change. And then if everything's the same, we're going to go ahead and do another 6 months, and that's a whole year of observation. And if that stays the same, we'll see you in a year. If it's a TH4 or 5, we're having you back in 3 months. And this is all based on tumor doubling time. So what we're going to be doing is getting a patient back in half a tumor doubling time, so we don't wait too long. And when it comes to a TH3, we're getting them back in 1 tumor doubling time.
Okay.
So there's a method to the madness. Yeah, absolutely. And when you were talking about, you were talking again about estrogen. I want to kind of back up here, and the progesterone. This is very, very important for your patients to understand. When we were doing this early on, we would have patients that the breasts were, this is estrogen dominant / progesterone deficiency. The research shows this. We can actually grade that. We don't do that anymore in the report because it confuses patients. We just use wording. So the patient comes back, and you go ahead and again, as I was mentioning to you before, I practiced functional medicine through chiropractic for 30 years. So we run all the labs, and everything comes back pretty darn normal, maybe even optimal for the patient, or their estrogen levels are low. Why does the breast look like this? Well, we've got modern research now. So what they have found by taking core samples of the breast is that the breast itself can make up to 50 times the levels of estrogen that can be found in the blood, saliva, or urine. It's hiding from you. So what's interesting here is you and we take care of the patient based on optimal function, but the breast's doing something by itself, and the only technology that can see it is thermography. So now you can treat the breast directly on its own to work on this. It's fascinating.
Really, really good way of putting that. So the breasts, in a way, are their own estrogen producing
tissue. Yeah, exactly.
organ,
I mean,
tissue,
yeah. We're looking at an acer gland. We're looking at a primitive skin gland that's sitting on top of the thoracic cage, and sometimes it has a mind of its own.
Mm-hmm. Interesting. So, at what age do you think general screening of any of these modalities should begin? Especially now that we're seeing all these younger folks have breast cancer.
Well, again, we can look at all the risk factors the patient's under conventionally, but we usually recommend that they start at 20. And if everything's fine, every 3 years until they're 30, and then every year after that.
Till 30 and every year. Okay, I'm going to write that down. I think we've covered breast pretty good. Just quickly, tell me what other things that thermography is really useful for.
It's very, very good for pain conditions, conditions that are either not responding to treatment or have another cause, because you're actually looking for the cause. Where is this really coming from? And so with pain, we're able to map out things pretty well. And so, I mean, I don't know, again, your practice is different from mine, but a lot of people are coming in, and the reason the patient's walking in is they're in some sort of discomfort. Yep. And so this is a huge area, helping patients get out of pain so they can regain their life. And I used it a great deal. I have a sports specialty, so I've worked with Olympic athletes, professional athletes, and looking at injury. So the patient, it's this world-class athlete, or even, of course, the weekend warrior. You have someone who's injured, and now they need to rehab. Is there residual inflammation? Is the treatment efficacious? And now we get to the point where we're going to put this $1 million athlete back on the field. Are they play ready? Well, no, actually, the inflammation is still there. This person needs more care before they tear themselves apart. So it works very well there. Now, what we do have is a problem called the internet. So now we have all these wonderful pictures showing how you're screening for internal disorders. I ask anyone, if they're telling you that, please go to the office and have them hand you 2 peer-reviewed studies from reputable journals that have thousands and thousands and thousands of patient participants that says Thermography is as good as a pap smear, a colonoscopy, a chest x-ray, blood tests. Prove it. Because guess what? There is no literature. So using this technology as a screening tool for internal disorders is dangerous and should never be used. There are so many better tests. You know that from your practice, and I do too.
Yeah.
So it should never be used for that.
That's very interesting. I do a lot of sports medicine as well, and that'd be a great tool. You know, whenever we're doing a deep joint using ultrasound guided PRP, for example,
Sure.
it's always very useful. Um, you know, but I've heard the same thing, and again for intra-abdominal stuff, I would never recommend thermography. Is that what you're saying as well?
Absolutely. I mean, we don't even take abdominal views because of the confusion to patients. They are extremely confused. Even if you tell them you're not doing this, they don't understand because they're used to other technologies. You know, we're not looking inside the body. Now, mind you, are there neural reflexes, we call them viscerosomatic or viscerocutaneous reflexes, that come from an organ that can display on the outside of the body a problem that might be with that organ? Yes, that can happen. Now, does that mean it's early detection? No, you have to have a certain amount of irritation to that organ. And then that's not early detection. There's been something wrong long before. And the signal can burn out. So I've got plenty of images. I've got tens of thousands of images over the years. And I have patients standing in front of me, in front of the camera, and they have stage 4 colon cancer. And it's normal. Okay, so we've got a lot of research that says, well, yeah, we might, but you cannot tell a patient, oh, please come in for screening for all these things because that's life-threatening.
Yeah, I agree. I think it's very important that that is stated.
Mm-hmm.
So, you know, this is so encouraging, and it really gives us another tool that we can
Mm-hmm.
really use on women. Um,
And in
and
prevention, it's
it's just
outstanding.
it's just amazing that what I've learned in the last few days, and I can't wait to get that technology into our offices. And I'm just pumped as I can be about it. And certainly the fact that you've come on here with me today and educated me, I certainly recognize you as one of the world's foremost authorities on this. There's no question about that. Go look it up. I mean, if you ever look it up,
You're too
his
kind.
name is your name's going to be in there. So I checked it out before I actually made the call to see if you would agree to be on a podcast with me. But
Sure.
so this is enlightening. This is hopeful. This is another great tool that we have in medicine to prevent bad things from happening
Mm-hmm.
to you. So, Dr. Beal, thank you so much for coming on here today. I hope to get you on maybe in another year or so after we've had this going. We can just sit and chat and
Sure.
see how it's going, the kind of follow up we're getting, the kind of patients we're getting, and so on and so forth. It's just been so encouraging to talk to you, and I thank you.
You're very welcome. It's been my pleasure.
Thank you, Dr. Bill. Guys, we'll see you next week on another edition of the Common Sense MD. I'll see you next week.